Hey everyone, thank you so much for coming back to the DisInformation Chronicle. I'm here today with Carl Heneghan. He's a physician and professor of epidemiology and evidence-based medicine, although evidence-based medicine is not in style right now at Oxford University. We're going to be talking about the controversy happening at the CDC. Back in April, there was an initial story in the Washington Post that the acting CDC director, Jay Bhattacharya, had shut down a study that was about to be published in the CDC's journal, which is called MMWR, or Morbidity and Mortality Weekly. It's an unpeer-reviewed journal that's the voice of the CDC, and they were about to publish a study that found very high positive effects from the COVID vaccines, and Bhattacharya shut that study down because it used a particular technique called test negative design. A lot of people have problems with it because it's not very effective. It can either be false negative or false positives. There was actually a ground rounds at the CDC discussing this very issue. I'm here today with Dr. Heneghan to have him explain to us exactly what a test negative design is, why it's controversial, and why you would not want to base public health policy for vaccinations off of test negative design. First off, what is a good study? And then what are the problems that we have with test negative designs?
I know you started this discussion with EBM, evidence-based medicine, not in fashion now, but it was in fashion, and I'm sure it will be again when people start to realize that actually the best available evidence is really important in making decisions. When you license a drug or vaccine, you have to produce a randomized controlled trial. The important thing about a randomized controlled trial is you take two groups of people, you can flip a coin, use a computer, and you allocate one group to the intervention and one to the control. When you do that, the idea is that you distribute the confounders equally amongst the two groups, apart from the intervention under test.
Can you explain, Bill, what are confounders? What exactly are those things?
Okay, before randomized controlled trials, what would happen is if you're developing a new drug and you go, well, I want this definitely to work. What I'm going to do is give it to the healthy people. And what I'm not going to do is give it to the unhealthy people. You're a bit overweight, you're a bit older. So basically, why give you the treatment? And so when you look at the effects of the treatment, you're not seeing whether the treatment works. You're establishing that the people you gave it were more healthy. And this is the complete problem with observational studies. Perhaps the best example of that is HRT. When we first looked at observational data on HRT, the women who used to take it were more healthier, more exercise. And so when you looked at HRT, you went, oh, it's a wonder drug. When we subjected it to randomized controlled trials, in fact, what you found is a reduction of that effect. And in fact, what it did, it increased some adverse effects.
Just so I can explain to people, HRT is hormone replacement therapy.
Yeah, correct. Correct.
Right. Yeah.
And there are numerous examples where the evidence from observational studies has been overturned by randomized controlled trials. In fact, indeed, the best example, which led to the birth of an evidence-based movement, was the cardiac arrhythmia suppression trials, CAS trials in the 80s and 90s, when people were given antiarrhythmics. Observationally, they said what they did after a heart attack is we think they make people live longer, healthier, and reduce your risk of another heart attack. But actually, some doctors questioned that. When it was subjected to randomized controlled trials, what it actually showed is the drugs actually killed more people than it actually helped. And in fact, I've got a book behind me that shows it killed more people than in America than in the whole of the Vietnam Wars. And so that was a real understanding. Late 80s, 90s, we got it. You need randomized controlled trials at the top of the hierarchy for drugs to be approved, but not only drugs to be approved, to establish in who they work and who they don't work.
What are the downsides of randomized controlled trials? So the one that's most obvious is they're expensive. They're really expensive and hard.
They used to not be expensive. So if you look at a drug like aspirin in heart attack, there are over 200 randomized controlled trials. So in the 80s and 90s, randomized controlled trials were relatively cheap to do. We used to use simple methods, like if you were on my ward, I could randomize you with a flip of a coin. What happened with regulation and maximizing the sort of validity of trials, trying to make them more robust, the cost escalated. So they are now incredibly expensive to do. And what you find now is, whereas you had 200 or 300 trials with aspirin in the 70s, 80s, and 90s, when a new drug comes along now, you just get one big mega trial, and that's all you get. So they're expensive. The second thing they don't do is they tend to be not powered to detect rare harms.
Right.
So things that might occur in 1 in 100,000 people in vaccines, if you only trial it in 30,000, you won't pick it up. They
Right.
also sometimes are too short to establish all of the harms as they occur. So if you do a trial in a vaccine for 28 days, you might not see the 3, 6 months, 1 year down the line harms. So there are disadvantages to randomized controlled trials, but in effect, they are cheaper. Because if you've got 100,000 people you're about to give a vaccine to, first off, your 50,000 aren't going to get the intervention because you're going to randomize those to the intervention and all. And number two is you're going to work out whether they do make a difference or not. And this is the purpose of evidence. High quality evidence you should implement where it makes a difference. And when it doesn't, you should stop, save your money, and go back to the drawing board.
This can be said in sort of a broad sweeping terms. The way I've often thought about it is randomized controlled trials are the best to determine if something works or not, but they're not that good at detecting if something's actually bad because you don't have enough population that you're testing in. Sometimes you get some drugs that come on the market and they've only been tested in maybe 1,000 people, 1,200 people, and you only see effects when it's out in the population and millions are taking it. And then you see it in 1 in 20,000 people, there's a heart attack. Is that pretty clear? An RCT is good, the best way to judge if something works or not, but observational studies can be very good at detecting if there's actually side effects.
Yes and no, because you've still got when it's a sort of barn door effect, I'm thinking of things like Vioxx, rosiglitazone in the DREAM trial. What happened there is it was quite clear there were harms, but what happened there is another problem, reporting bias. What
Right.
happens is in those small publications that appear in the Lancet and New England Journal of Medicine, they bury the harms in the background. And
Right.
that's why you often have to go to what's called the clinical study reports, which when they're submitted to the regulators, often these things will come out then if they're doing their job. So the common harms, which can be serious or not serious, randomized controlled trials are good at picking up. The long-term harms, no, or the rarer harms, no. And that's important when you're going to roll out something like a vaccine where you might trial it in 20, 30,000 people. But if you're going to give it to 10 million people, then if 1 in 100,000 is going to die, then suddenly you can see you end up with like 100 people dying. So that's really
Right.
important. And in effect, that's what happened with the Oxford AstraZeneca vaccine is the trials didn't pick up the issue. Regulators were too slow to act, and people started to say, there's a real problem here. Where was it in the trials? Well, it didn't get picked up and it wasn't accounted for.
That's what happened with rosiglitazone, what we called Avandia. I ran the investigations in the United States Senate on that.
Right.
You didn't see a signal in any of the clinical trials, but what happened is afterwards, when you combined all those trials into a meta-analysis, that's when you saw the signal. I actually did the review for the Senate on Avandia, so I had all of their data from GlaxoSmithKline. I would look at the clinical trials, and after a while, I started to see a pattern, and I would see a study, and I'd put my hand over so I couldn't tell which arm was which, whether it's rosiglitazone, this one or this one, this one, and I'd be like, I'll bet you this one's rosiglitazone, where I'd see a side effect, and I would
Yeah.
keep seeing that, but like, of course, that doesn't mean anything mathematically. And what was funny is when we brought in the FDA to come talk to us, the senior FDA person who looked at rosiglitazone was an MD, PhD in either biostat or epidemiology. And she told me she did the same thing too. She was like, I see something. I can see that there's something that make me want to ask more questions, but the companies didn't want to look at this, whereas I did. So part of the way that happens is these companies bias their trials. Trials gets biased in a certain direction.
So it's interesting. Avandia rosiglitazone, this was a drug that was targeted at people with diabetes to reduce their blood sugar. Another really common error, but actually is not an error for the industry because they use it, is using a composite outcome. So what they did in the trials is use a composite of diabetes and death, which was incorrect to do that. But what they said is it reduces your risk of diabetes and death. It didn't reduce your risk of death. It reduced while you was on the treatment, it lowered your blood sugar, so it reduced your risk of diabetes, but not death. Importantly, what you're saying is there was a signal in the background. The signal was there, but not statistically significant for an
Exactly.
increase in heart failure.
Right.
And that heart failure, the NHS, the number needed to harm was about 50 to 100, so it was quite low. in effect. So if for every 50 people you put on the treatment, one person would have an extra risk of heart failure. And this was in a low risk population. So as soon as you translate it to a high risk, you've got real issues at hand. And so you're right. What happened there is the use of what I call poor outcomes. So that's another issue to remember with RCTs. When they go to the time of approval, they often won't use the critical outcomes for decision making. They may use surrogates. They may
Right.
use composites like diabetes and death, which is incoherent but gets accepted. As in terms of vaccines, they may not use the important outcomes like you're really interested in hospitalization, bacterial complications, you may be interested in death, but they'll produce a surrogate of antibody response.
Right.
And this is where medicine is going wrong. We are accepting a lower bar of evidence, even within randomized controlled trials, to get drugs approved. And yet what happens is then on the market, we're still left with questions of, does this work? Important principle. You alluded to it. In terms of post-marketing surveillance, it is not there to establish the effectiveness of drugs or vaccines.
Right.
It is there to say, what are the real world effects here in the population? Do they translate? And what are the harms when we roll it out to a wider spectrum population who may be at vastly different risks than the people who are in the trials? And a good example of this is the elderly or very elderly. Most vaccines do not trial in populations over the 65. They do a few in 65, generally 75 maybe, and over 80 never. So,
Right.
but yet we go and use them in these populations all the time. And we have to then go, well, what happens when we give it an 8-year-old? And that is a
Right.
really important issue. You then go to, in the post-marketing world, when we get a vaccine approved, what happens is year on year, when you do it as a booster, so many people will now be aware there are still COVID boosters available. Somebody doesn't come around and say, right, you need to do a new randomized controlled trial. You can just have approval. They'll do some lower bar quality to say it gets the same effects and we'll use the test negative design to prove vaccine efficacy.
Right.
That is a fundamental flaw because what we're doing is using evidence that is not designed to ask the question of, is this effective in the real world? Now, the test negative design is a form of case control study. It means you can get normally people with disease and people without disease, and then you compare them for certain outcomes in relation to certain exposures. They are important in some areas. So, for instance, you can't randomize people to certain interventions. Mobile masks, for instance, say you're interested in cancer and mobile masks. You can't say, I'm going to randomize you, Paul, to live near a mast. What we have to do is say, actually, we look for the outcome of interest, like the cancer, and then we ask you questions about where you live and compare
Right.
the cases and controls. The second area there, very useful, is in rare diseases. So some diseases are so rare, you can't do a trial and say the outcome of interest is childhood leukemia of this type because it's 1 in 5,000. So you just
Right.
can't do the trial. It's so expensive. A classic example of this, I teach this one going back to the 50s and 60s. We did a childhood cancer leukemia survey. And what we showed is that basically the cases of leukemia in children compared to not, and they matched for certain things like age, deprivation, other siblings, were exposed to X-rays in utero. And that doubled your risk of childhood leukemia. Believe it or
Right.
not. So we used to, so this shows you how insane medicine can be. We invented the X-ray machine, a radiographer, and we decided to use it in pregnant women in the first trimester to look at the size of the birth and the child and the bone
Right.
structure. And we doubled the risk of cancer. Took till about the 70s for us to stop doing that practice. Some places still did it. So that basic principle is the principle of test negative designs. Take cases of people who test positive to influenza and those that are negative to influenza, and then ask them certain questions like, did you have vaccine or not? Importantly, what they try and do is to match them is they say, we'll take people symptomatically turning up at hospital or at general practice. So 100 people turn up, you test them all, 20 of them have influenza and 80 don't. You then ask
Right.
them questions like, did you have a influenza vaccine group and a non-influenza vaccine group? And so All the test negative design does is tell you whether a group of people who had a vaccine are more likely or not to test positive on a PCR result for a certain influenza viral strain. There are, just like all of case control studies, there are significant problems, as we started this conversation, with the confounders. The people who turn up can be different in both groups. But there's a really interesting bit. The people are symptomatic, and you're saying in our test negative designs, which they always do, is show results that show the people who test negative are more likely to have the vaccine. Test negative
Right.
design. That means that they're more likely to test positive for something else. Nobody ever seems to get this. So what is it you're promoting? Is it they're more likely to get SARS-CoV-2, RSV, or some other virus? Because they're symptomatic. They're turning up with influenza-like illness. So if it's not influenza, what is it? So that's the first bit. The second bit is the groups differ in observational studies substantially. So the first thing is you can't prove mortality with these designs because you've got to turn up and be symptomatic. So if you died at home, you're not going to get in the study. Often the design means if you did it in general practice, you're not going to pick up the people who went directly to hospital.
Right.
You're not going to pick up the people who were intervened in general practice. You're also going to have people behave differently. So if I've had a vaccine, I might think I don't have to turn up. And I might only
Right.
turn up if I'm really unwell. So they really don't tell you very much apart from the ability to test negative in a group of people who've turned up and symptomatic. And you can ask them a multitude of different questions, and you'll show lots of spurious reasons why they may test positive or negative.
If they're not that great, why then are the people at CDC in love with this test negative design?
Well, number one is you've got a problem. Every time you roll out a vaccine, you haven't got any evidence to support what your policy is. So you haven't got any randomized controlled trial evidence. So you need some evidence to inform not the government, but the population why we're doing this. So, this is fitting evidence to policy. And the benefit of test negative designs is that they're cheap, they're really quick to do. And modern computing methods, you can get the answer really quickly. And you can generate an odds ratio, which is, you know, 3 times more likely to test negative if you've had a vaccine. And that's not what you're interested in if you
Right.
have an intervention. What you're really interested in is, does it stop me going to hospital? Does it stop me getting bacterial complications? Does
Right.
it, if you're elderly and over 80, does it actually prevent mortality in care homes? So the reason we see this lower bar evidence flooding the hot landscape now is our failure to do the randomized control trials. And there's one single reason. It's not the cost. There's a lack of will because often people are concerned about the answers they might get if they do the RCTs.
I did an interview with the NIH director, Jay Bhattacharya, about this article I saw in the New York Times, and it looked at people with long COVID. And the conclusion that was in the New York Times was that vaccination stopped long COVID, which I knew was weird because the trial started in 2022. We didn't even have a definition for long COVID in the United States until 2023. The trial runs from 2022 to 2024, and yet they were looking for something that was not defined until more than halfway through the study. How do you conclude anything off this study? From my perspective as a journalist, because of course I'm not always reading all the academic literature the way you are, I'm looking to see what pops up in the media. And the reason why we're talking about this today is because this acting CDC director came in and said, guys, we're not doing this test negative design. These CDC employees ran to the Washington Post. They ran to the New York Times, started screaming their head off. We can't publish this trial that shows how amazing the COVID vaccines are. And then when you dig a little bit further down, what you find out is, well, they don't want you to publish it because they don't think it's a very good study design. It's not that they're scared of the results. They're scared of the type of study you're doing. They don't want you to do these types of studies anymore. Because if you do a real rigorous study, you don't know what's going to appear at the end.
The first thing is to say, when you really want to know what the effects of an intervention like a vaccine are, I always go to the summary of product characteristics. Because although the industry may do trials that we have problems with, they always are not stupid. The product label, which goes to the FDA or here in the European Medicines Agency, is the important document. So, for instance, when Fauci said the vaccine's a dead end for virus, he was basically saying they prevent transmission. Yeah, if you go
Right.
to the FMPC, you look at the label, there's nothing about transmission, and Pfizer say we didn't even study transmission.
Right. That was so funny because after they said it stops transmission, and then people turn around and said, well, it's not actually stopping transmission. Then they changed it and they said, well, they never studied it to stop transmission. Stop lying to people. You're like, wait, hold on. Wait, you
Oh,
told us one thing, then you changed it. And then when we
good.
caught you, then you changed it back again to the
Mm.
first thing.
Which is the same argument then for long COVID. If you want to, number one, give us a definition of what you mean by long COVID, then do a trial. Because, look, these are important trials to do. But the problem
Right.
is people are really concerned that actually, like most interventions, even if they show a benefit, it's often tiny. And in low risk populations, the potential harms will outweigh those tiny benefits. And so what we have is this world where people revel in uncertainty and overnight can become experts and tell you this is what you should be doing. Your CDC has a particular problem, which is ideology then invades. They're not testing whether something works. They're trying to prove what they think works. In doing so,
Right.
test negative designs are really good to do that. Now, this is a problem in the debate. I could design a study, for instance, that can show you vaccines are lifesavers. I'll give it to healthy people and not healthy people and look at them differently. So, for instance, a good example of where you get bias is in people who are dying in the last few months of their life. And I see this all the time. They're palliative care, end of life care. They've stopped participating in preventive actions. They may not even be taking their medicines, their statins, whatever. They're basically accepting they're in a pathway 3 to 6 months. When you analyze that group, you say they died in 6 months and they didn't have their vaccines. Therefore, vaccines save lives.
Right.
So you see, you can sway research any way you want when you become ideological. So what the CDC are trying to do, if they're correct, is I don't believe you should not censor research. You should still publish your research. But in doing so, number one, you should set out the clear question up front and the need for it. Address what is the highest quality of evidence. And if you're not going to do that, what you say is, this is why we're doing this. You should publish a protocol before you start. And indeed, what you should do is publish the limitations. These studies often only follow people up for 3 to 4 weeks. What
Right.
about 8 weeks, 12 weeks down the line? People have a vaccine, and at the point of vaccine may change their behavior for a few weeks. That's why they reduce their risk. You don't follow them up long enough. So what we need to do is have a return to robust science. But the problem is at the moment is it doesn't fit the narrative.
Right.
And at the moment is we won't, when we start this conversation, we won't return to an EBM approach until people get it that there isn't enough money to go round with the current strategy. We can still increase the amount of money we spend on healthcare quite substantially. And at the moment, we're focusing on diseases where we've got poor quality evidence and we don't understand how to intervene to improve what's going to happen next. And we in this country, for the last 25 years, have had the same strategy dominated by antivirals and vaccines. And yet, as we enter winter, 3 out the last 24 or maybe 25 years, there's been a winter crisis in the UK and the NHS. So whatever we're doing now isn't working. And we keep rolling out interventions with no testing or evaluation, keep wasting money, and we seem to lurch from one crisis to another.
The acting CDC director told CDC employees, you can't publish this study. They then ran and leaked it anonymously to the Washington Post. Lena Sun, who's one of the favored
Mm.
journalists for people when they're angry and want more vaccines and more vaccines. Here's what she reported to explain why test negative is so awesome. She said a report about flu vaccine effectiveness this last winter using the same methodology was published in the MMWR a week earlier. That methodology, which means test negative, was also in a 2021 study on COVID vaccine effectiveness in clinics and hospitals published in the New England Journal of Medicine. Vaccine effectiveness estimates using the same methodology have also been published in JAMA Network Open, The Lancet, and Pediatrics. If this particular design, as you're saying, has problems, that it's not effective because it's not really giving you an objective control, why then do these journals suck these studies up? The Post is acting like this shows you how great they are, but you're saying they're not good. So then why are these journals publishing these studies?
Well, number one is a dearth of randomized trials. So you go to the next available evidence. And in doing so, you've got a problem of publication bias. So they're all positive. positive findings are twice as likely to be published as negative findings. They
Right.
support a political position. Many people have an ideology that these things work, and therefore they like to pull evidence. There's a whole industry behind it that supports it with advertising and marketing costs and conference support. So, as far as I'm concerned, the journals are not independent anymore and not the purveyors of truth.
Let me just say something. There was an article that came out, the Wall Street Journal, I think 20 years ago. I'm going to find it. I'm going to post a screenshot over here. I can't remember which journal it was. It was the New England Journal of Medicine or JAMA, about how much money they make off of preprints. When this hit the Wall Street Journal, I mean, this was like 20 years ago. So we've known this for like a couple decades now.
Yeah, yeah, and you talk about the NEJM, the Massachusetts. It's a Massachusetts medical
Yes.
society, isn't it? It's one of the most
Yes.
influential in the world. I'm just looking how much they brazen. I mean, you go back ties with 20 drug companies. Huge amounts of money that these
Right.
people got now. So this has got to go with this. So you remember we talked about Vioxx, didn't we?
Yeah.
The Vigor trial, published in New England Journal of Medicine in 2000, underreported adverse events, including heart attacks and deaths. The bottom line, however, New England Journal of Medicine, Merck bought 900,000 reprints of the article for motion, at an
Right.
estimated cost of somewhere between 700 and 850,000 US dollars.
Right.
Anybody
Right. So,
need any
so
more about what's going on about the
just so
police
I
and
can
what's
explain to you what happens is when one of these trials get published in the journal, the studies actually belong to the journal. So if you want preprints, you then have to go and pay the journal for more copies. Well, what happens is the pharmaceutical companies go to the journals and they'll spend a ton of money to get preprints, which puts money in the pocket of the journals, and they'll take those preprints and they'll hand them out like candy to doctors all over the planet. And so that's the way you create positive feedback loop. Same thing happened with the COVID vaccine. I wrote about some of the problems with the COVID vaccine. The editor-in-chief, Rubin at NEJM, was on the FDA panel that approved the COVID vaccines from Pfizer. And then they ran that clinical trial through New England Journal of Medicine, which gave them all this global advertising about how they were publishing the clinical trial. Who knows how much advertising that created for New England Journal of Medicine when people started writing about this 95% effectiveness.
Maybe
Initial
I can
clinical
give you an
trial for
answer to that.
Pfizer.
ProPublica, who produce information, report the Massachusetts Society revenues of $125 million in 2023.
Right,
The majority of that income is from the New England Journal of Medicine.
right,
We estimate that subscriptions to the society bring in about $11 million a year, based on
right,
24,000 members. So the difference between subscription income and revenues or income is about $114 million a year.
right,
Not bad if you can get it.
right.
That's what's happening here. I think no other industry would be in this situation where a single journal, or maybe two with the Lancet, has so much influence over decision making and what happens next. But
Can I
that
ask?
goes to the heart. They'll publish these test negative designs if they support, they think, a particular position that'll improve their position as an organization. That's standard business practice, you know. The fact is, when we started in the world of EBM about 95, there was a huge appetite for improving the quality of evidence and publishing that evidence in full. And there was lots of energy. Cochrane started about then, NICE here in the UK, reporting standards like Consort, all of that came about, trial registration platforms. There was about a 10-year era where there was a real emphasis and impetus to improving the quality of evidence. But actually, the last 2 decades have been more about subverting that process to actually increase revenues and promote positions which are not in the best interest of patients. The problem is you've got in the US is there'll be another, at some point, a change of emphasis in government, and then you'll rehash the whole situation. And I suspect with that change in government and change in emphasis, you'll see the over promotion of test negative designs again.
There's one thing I want to get into. There's an article I read today. It was actually in the Washington Post by the same reporter, Lena Sun, who did this initial report where the CDC employees leaked to her, keep shutting down this test negative design, right?
Yeah.
And it was a scare story about all these possible infectious diseases that might pop up in the World Cup taking place in America. This has been a really weird issue because since Trump has come in and Robert Kennedy, who was a lightning rod for, I don't necessarily agree with all the things he does on vaccines, but he is asking some legitimate questions about vaccines and how they're being promoted sometimes without evidence. Since he's come on the scene in the United States last year, it was wall to wall coverage about measles. You would see a story about measles every week in Stat News, which is basically the mouthpiece for the pharmaceutical industry, just wall to wall news about measles. Do you know how many people, Americans, died of measles last year, despite all this coverage?
A couple of hundred.
Two or three. 2 or 3 Americans died of measles last year. The reason I say 2 or 3 is because I think one actually died. Well, you could say he died of a secondary bacterial infection. So whether you attribute that to measles or not, or the secondary bacterial infection, you can argue over. Okay.
Oh,
Then this year, you have wall-to-wall coverage, right, of hantavirus.
I was
Do you know
about
how
to
many
say that.
Americans? Do you know how many
No, no,
Americans?
no. Let me ask you: how many
Yeah.
cases in the last decade has the UK had of hantavirus, and how many deaths?
I would say maybe, well, I don't know cases. I know how many Americans died in the last decade of hantavirus was 100. And
Okay.
I don't know if it's even endemic to the UK or not.
So we've had 12 cases in a decade and no deaths.
Okay. So we've had 100 deaths in the decade. Now it's just switched over to Ebola. Okay. First off, guess how many people have died globally ever of the evers of
500.
Ebola virus?
About 500. Oh, maybe a couple of thousand.
15,000 in the
Yeah.
last 50 years. Okay. Do you know how many
That's
Americans died?
assuming that's assuming that the case ascertainment of the death is correct, because one of the
Correct. And there's
problems we've
probably
got
because
is
because
we
because these
can't
are taking place
verify
in
anything.
Africa. And because they're taking place in Africa, we're not going to see all of them, right? But
Yeah.
guess how many Americans die every week of cancer in America?
Oh, yeah, tens of thousands. But what about the most improminent?
12,000.
Yeah. What about TB deaths worldwide?
That I don't know.
About 1.3 million. Now, the biggest thing what happens here is the transmission trick. This is what it's all predicated on. The notion that the disease can be spread. So that's why we think the risk of transmission is low, but it's theoretically possible. Therefore, we're going to write about it and scare you all to death. So that's why
Right.
the Ebola, the hantavirus, are keep perpetuating. It's this transmission risk. It's the same with the COVID. It's this invisible infection killer that you are going to spread. Therefore, we all have to intervene. We need vaccines, we need locking down, we need masks. So we've got a complete inversion at the moment of the risk to the population, which you're right, cancer, diabetes, obesity, dementia. Huge, in fact, you could consider pandemics, versus this complete focus on infections. But what's the difference is there's money to be made in the testing, there's non-pharmaceutical intervention, the masks, the vaccines, the antivirals, huge amounts of potential new funding streams to come on. And this is the problem for all organizations. They're becoming self-serving.
Right.
WHO, Tedros has to go to Congo to be seen. But you're like,
Right.
"Oh, I thought this was a deadly killer. Surely he shouldn't go in and come back out." But, no, what it is about raising the profile to bring in more money so we can keep going. But every logic tells you nobody should be going in there and nobody should be out if we're supposed to believe you. So
Right.
there's a disconnect now in the world in terms of the problems we face. We have it here, same as you. We have the UK Health Security Agency. The budget is in the billions, and basically their job is almost to keep themselves in business as opposed to do anything around healthcare. So that's why you're seeing this policy first, evidence late second. And in doing so, we don't really care about the quality of the evidence because most politicians won't know the difference. We still relying on modeling in this country. So let's forget the test negative design. That's way up in the echelons. You know, let's make up assumptions and draw a nice little curve and say we'll save you all. So until we get the basic principle that each year you should do a new randomized control trial. And if they say you can't do it because there isn't enough people with infections or illness, then you're saying, why are we bothering in the first place? I thought you told us
Right.
this was a huge issue. And that is a real problem. So when you talk about 100 people with symptomatic illness, even at the height of infection, only 4 or 5% of them will have influenza. 95% will have something else. And these are all other infections. And the only ones we talk about now are coronaviruses, RSV, and influenza. All three of them have vaccine candidates. You don't hear anything about the other ones, adenovirus, metanovirus, rhinovirus, we could keep going, Bocavirus. All these other ones that actually in care homes are a disaster. You don't hear anything about them. So the burden of illness is influenza-like illness. We are understanding at this moment of time about what works and what doesn't is extremely limited, despite the fact we're in a golden era of knowledge and information.
As a physician working at Oxford, are you scared of dying from measles?
No,
Are you scared of dying of hantavirus?
not even the remotest, not even close.
Are you scared of dying of Ebola?
No.
What are the real fears that people such as yourself living in England should be concerned about?
One of the biggest fears here is because most people in Oxford ride a bike is potholes, and potholes on the road are a disaster. About 450 people die or have serious adverse events while riding a bike, so you've got to be careful. So basically what you're alluding to is our ability to understand the risks of what matters and what doesn't. As you get older, you've got to stay in shape, look after yourself, eat a good diet, don't smoke, because the risk of cardiovascular disease is massive, stroke and dementia. But also cancer care is suboptimal in this country. And I put that as I'm not fearful of getting cancer, but I'm fearful of having inadequate treatment. I'm also fearful in the next couple of decades, we won't see the woods for the trees because we've got this deluge, if you like, tsunami of poor quality evidence, and we're not prepared to do the right studies and work out what works and what doesn't. So we may not see many advances in the next 20 years, but there'll be lots of claims about on the horizon is AI, this treatment, that treatment, but actually we'll make no advances. And that's my real concern.
Carl, thank you so much. And thanks everyone for joining us today. If you can, please subscribe and keep coming back. Carl, again, thank you so much for coming.
You're welcome.